computer as well.
It is on full screen, right? I mean, for me, it is.
No, it's not yet. Just a second.
Can you do that? Because mine is showing full screen here to me. So,
A minute. Yeah, done.
done? Okay.
So,
So,
good evening, everyone. Welcome to Bombay Ophthalmic Association PG lecture series. As you know, we are dealing with all the basic topics which are very important for the PGs for clinic point of view and as well as for the exam point of view. And one of the topic which is a bit of a neglected topic but a very important one is macular dystrophies, and we will be covering only part which you must know in your residency and as an ophthalmologist, uh, irrespective of your being a retina surgeon or not. And to teach us, we have Dr. Harshit Vaidya with us. He has done his DNB and his retina fellowship from Shankar Netralaya, and at present he is working in Mumbai in Dr. Vaidya High Hospital. Thank you, Harshit, for accepting the invitation and giving time for all of us for teaching our PGs. Over to you.
yeah, thank you, Dr. Sumit, and thank you to the BOA Association, to all the seniors who've given this opportunity. Before thanking and before starting, I mean, I realize that these COVID times are tough times for all of us, especially for our residents who've had to learn, and especially who come in the first year, who are in final year. They're having to make do with this new way of learning. I'm sure clinics are way more interesting. Seeing patients obviously is more different in terms of learning, but BO has obviously done a fantastic job at giving you guys the best possible way to learn, and this is one of that, right? We are coming to the fag end of the year. Although I'm sure like you guys are exhausted with all the lectures and seminars, and you've been great at attending. But so this is a fairly important topic. Why it's important? It has clinical importance. What we'll end up doing is land up missing up these pathologies, right? The macular dystrophies, they are relatively common. I wouldn't say they are as common, but and in terms of exams, there are these short cases that you get, and sometimes you will end up getting long cases as well. So we're gonna basically once, Dr. Sumit, it's I'm not able to change the slide.
You might have to do it with the left lower corner of your PowerPoint presentation. There will be arrow on, yeah. So use that arrow for
Okay,
first
sure.
two slides. After that, it will be easier. Yeah.
Sure, sure. So we'll be covering this slightly large and vast topic in the most brief way we can. Mr. Tejal or some, anyways. So we'll be covering it as how do we approach these patients, right? So we have macular dystrophies as a part of something called as inherited retinal disorders. So we'll in general see how these patients are to be approached in terms of clinical practice as well as in terms of your theory exams or your practical exams. Then we classify these macular dystrophies, and at the end we learn the salient points of these few important dystrophies, right? So before going ahead, right, we always need to know why we need to evaluate, why we need to know about these diseases and what's the importance. So what did the AAO, right, in 2016 made a clinical assessment and about these inherited retinal disorders. They said what was the objective of this learning about or evaluating these conditions. It is initially to establish the correct diagnosis, right? What it does is it helps us having an appropriate patient care. It helps us know the prognosis. In cases of these patients usually have a poor prognosis in terms of long-term vision, hence providing them with low vision care and assessing and monitoring comorbidities and other systemic involvements. We get to know about the genetic nature, the transmission, and its affection in the other family members. And also, it helps us in knowing the ongoing and future trials and novel treatments. Ranks go, right. So this is Australia and New Zealand Ophthalmic Society, Royal College, who came up with in February 2020, came up with this guidelines for assessing and managing these patients with suspected inherited retinal disorders. This is as a short form IRD. Right? What did they suggest? Right? They suggested 4-step process in which first we establish the clinical diagnosis of these patients. How do we do that? History taking. Then we do a clinical examination and we have investigation, the 3-pronged approach to establishing a diagnosis of these patients. What it does is it helps us determining the level of visual function, right? Help in planning the visual rehabilitation. Then thirdly, it helps in establishing the genetic diagnosis and genetic management. Although in India, we do not have the vast array of genetic management and genetic diagnosis as opposed to the Western world, but certain apex institutes have started doing these diagnoses, and it is helping our cause for the future, right? And fourthly, but lastly, and more importantly, monitoring the disease progression and preparation for therapeutic interventions. So when do we suspect these disorders, right? When do we suspect that this patient who's come to our clinic has a hereditary disorder? Well, a familial nature of the disease, right? Having a bilaterality. The patient says that he has problems in both eyes. Usually these diseases are symmetrical. They're not as asymmetric as, let's say, DR could be or other ARMD could be. Then they have an earlier age of onset, as opposed to the other macular disorders or in old age degenerative changes which occur later on. These are earlier in onset. They usually have a slow progression. They are not like a retinal detachment or these complications which happen as a sudden loss of vision. And usually you do not find an extrinsic cause for these patients. Then comes history taking, right? When do we suspect? When the history, when patients have a similar complaint in family members, there is a history of consanguinity. There is a clear absence of drug history. And there is systemic illness. Certain inherited disorders like Usher's syndrome, Bardet-Biedl syndrome, we know are associated with retinitis pigmentosa. And hence the systemic evaluation is important. Then you have complaints. Certain complaints make us suspect that this could be a hereditary disorder. What could it be? A gradual painless diminution of vision, inability to fix or fixate or having nystagmus, dark adaptation problems, visual field problems, photophobia, color vision difficulties, right? So how do we evaluate these patients? We got to know that when do we suspect, right? We know there are certain pointers which help us suspect this disorder. How do we evaluate, right? AO, again, like American Academy of Ophthalmology, landed up giving us these guidelines and these protocols in which this is how a patient is to be assessed. It's a simple protocol in which even as a clinician, even for examination, these are simple, right? So what do? We have chief complaints. In chief complaints, the most common complaint is diminution of vision. What do? You learn about the onset, duration, the course, whether it is for distance or for near, whether the central vision is affected or the side vision is affected, whether there is night blindness or day blindness, whether there is photophobia, and other complaints like metamorphopsia or color vision abnormalities. History taking, as we've seen, ocular history, family history, systemic history, and in the end, medication history. We evaluate the patients clinically and investigations. Clinically, we do a best corrected visual acuity, color vision. We also check the intraocular pressure in certain patients who have an association with angular closure glaucoma. Then we do a proper slit lamp biomicroscopy. We cannot forget that although these are retinal problems, we should not forget to see the anterior segment. There are certain conditions, like you would know about BT's crystalline dystrophy. These dystrophies have crystalline deposits in the cornea. So we would be thinking that these problems are only in the retina, but they have corollaries in the anterior segment as well. We have a detailed fundus evaluation. We see the vitreous cavity, the optic disc, the veins and arteries, the macula and the posterior pole and the periphery. Investigations, there is a barrage of investigations that can be done nowadays, but the most important being the fundus photography and autofluorescence, OCT, electrophysiological tests whenever required, visual fields, and fundus fluorescein angiography, although it is used lesser these days. So classifying these disorders broadly, right? There are multiple classifications that are there. Each textbook will give you certain different classifications, but that's not a problem. You just basically need to know that there is a whole array of these diseases in which there are certain classifications. The mode of inheritance, these diseases could be autosomal dominant, recessive, X-linked dominant, recessive, or mitochondrial. Certain diseases are stationary, certain diseases are progressive. So by definition, dystrophies are supposed to be progressive inherited retinal disorders. That's when we use the term dystrophy. So we know that most of our topic for today, which is a macular dystrophy, these are going to be progressive disorders and not stationary disorders. Then you can classify them as central and generalized. On basis of anatomy, you have retina, RPE, choroid, and vitreoretinopathies. Certain syndromes and certain diseases can be isolated, and some can be syndromic. And based on age, we can have different inherited retinal disorders. Right? But in general, these disorders are generally classified on the clinical phenotypes. How are they done? Based on cone rod systems, in which cone rod dystrophy is the most common. There are cone pathologies in which retinitis pigmentosa is most common. Then you have chorioretinal degeneration like choroideremia, and our today's topic of macular dystrophies, in which Stargardts and other diseases are a part. So this is the most commonly used system But again, there is a general overlap and heterogeneity in these patients and in these classifications. So one book that you read could be saying that particular dystrophy is in certain category, but you do not need to get confused by that, right? So today's topic of macular dystrophy, these can be classified based on the anatomical layer in which these dystrophies are taking place, right? So in case of NFL, you have X-linked juvenile retinoschisis. When there are photoreceptor and RPE damage, you have Stargardt's and cone-rod dystrophies. RPE damage shows Best disease, dominant drusens, and in Brooks membrane pathologies, you have myopic macular degeneration, angioid streaks, and Sosby's dystrophy. And choroid has central areolar choroidal dystrophy. So this is the general classification. So do we have any first year who can just name the layers of the retina before you go through the entire process of macular dystrophies? Just the anatomical layers on the OCT. If anybody can just quickly name, so we move forward. Any first year here?
Uh,
Or second year? Just anybody can just take this up.
Can you please take this question?
Um,
Uh,
Even if there's a final year, this could be a question for you guys as well.
yeah, Meghna, can you just please answer it quickly?
Yes, sir.
Yeah.
Go ahead, please.
So from inside out, I'll be telling.
Sure.
So it's a layer of nerve fiber layer.
Great.
Sorry, first is the internal limiting membrane. Internal limiting membrane. Then the nerve fiber layer.
Okay.
Then the ganglion cell layer. Inner plexiform layer, inner nuclear layer, outer plexiform layer, outer nuclear layer, outer limiting membrane, photoreceptors layers, and retinal pigmentary epithelium.
Okay. Yeah, you're absolutely right. So what we do is the photoreceptor layer nowadays is split into, like it's said as after ELM, you have the ellipsoid zone, which is the ISOS, right? Inner segment and outer segment junction, and you have the interdigitation zone, and then you have the RPE Brooks complex. That's how it is. So great. That's how the retinal layers are. Right. So the Meghna, this is on the right side is a 50-year-old male with bilateral gradual diminution of vision with nil systemic illness. And on the left side of the picture, we see a 15-year-old male. These are two separate patients, and who has a BCVA of 624 and has similar findings in siblings. Can you just quickly describe the pathology? How would you describe this in the examination? We are not just a simple step-by-step procedure, right? If you're giving an examiner asks you, this is a picture that is given. How do you describe? That's all.
So in the 50-year-old male, basically I cannot see the disc that much, but the vessels seem to be a bit thinned out, and also it looks like a macular involvement with lots of exudates around the macula. And
so the better way to describe would be to go step by step, right? When an examiner asks, so how do we see the media is clear? What does the media include? It has the lens and the vitreous, right? So the media is clear. So how do this is a picture. It's a fundus both eyes fundus photograph in which both eyes show a clear media. Disc apparently appears normal with a healthy neuroretinal rim and with a dichotomous branching of the vessels, which is 2:3 ratio. The vessels are actually fine. There is no attenuation there. Then once you've described this, you come to the main part, right? What is the main part? The center, which is the macula. What is there? Can you just describe, like how would you try to describe it, right? Describe the lesion that is there. Okay, so how is it? It's a well-circumscribed area of possible atrophy, which is yellowish to orangish in color, with certain subretinal deposits, which are yellowish white in nature around the atrophic area. Is that okay?
Yes, sir.
We cannot say that it is a particular lesion, but we know that. How will we say it is subretinal? Can we say it's subretinal or interretinal or pre-retinal? Okay, so it's a simple thing, right? When the vessels are going over a lesion, if you see clearly, if you can observe these yellowish, whitish deposits, the vessels are going over it, right? When something is going over it, obviously something is under the retina. Make sense?
Yes, sir.
Correct. So something is under the retina. If it was over the retina, the vessels would be blocked. Correct. If there is a hemorrhage, the vessel will be blocked. Correct.
Yes, sir.
Great. So can you tell me what the picture below is? Do you know what that investigation is?
So that's an OCT macular image.
No. Okay, in the right image only, there are the C and D. Do you know what that is?
So fun
Okay, so it's an autofluorescence image.
autofluorescence image. Huh?
Correct. Can you describe the autofluorescent image? It's very simple, right? Nothing much here. Okay.
Some. Okay.
Go ahead. Try. See, we need to do it.
Yeah,
Go
whatever
ahead.
you're seeing, you can just describe.
Just describe, right? So we can move forward after that.
So the media appears to be clear with atrophied macula and well circumscribed lesion around the macula.
Correct. So in autofluorescence, we don't describe it in the way we do a fundus photograph. In this, you just two things, right? It is either hyper or hypo.
Okay.
Correct. So the central area is a well circumscribed hypo autofluorescent area with patchy small pigment hyper autofluorescence patches surrounding the atrophic hypo autofluorescence. Does that make sense again?
Yes, sir.
So fine. Can you by any chance come with the diagnosis of this patient? Would you be able to say that? Okay, fine. So this is a Stargardt's disease, right? We'll just know a little bit more about what Stargardt's is, right? So it is the most commonly inherited macular dystrophy with an incidence of 1 in 10,000 of population. The most common gene implied is the ABCA4, which is a ATP binding cassette 4 gene on chromosome 1, and it is autosomal recessive, correct? There is this term called ABCA4 retinopathies. These final years, you should know this because it's a term nowadays. It's not just the clinical diagnosis that we make, but since as genetic testing and diagnosis has become better, the classifications are now turning from clinical to genetic because these are more accurate. There are these things called ABCA4 retinopathies in which you have these certain disorders which are also caused by the ABCA4 mutation. Correct? What is the primary pathology in Stargardt's? It's the accumulation of lipofuscin, which we'll see in later in detail, right? What happens? How do these patients present? It's a progressive bilateral central loss of vision, and usually they have an earlier onset, around 6 to 20 years of age. Correct? The other problems that the patients can have is either they can have color vision abnormality, central scotomas, and slow dark adaptation. A characteristic feature for these patients is something called as a beaten bronze appearance. This is, you guys may be knowing this for MCQs, and even for Vivas, this will be important, right? So how does a typical patient of Stargardt's, a classical picture would be having a patient would be having macular atrophy with yellow-white flecks at the RPE level, usually around the posterior pole. And the most reliable diagnostic sign is relative sparing of the peripapillary RPE. Here, if you see the RPE here, there is no drusens or anything around, and that's usually the most reliable sign to distinguish it from the other inherited disorders, right? So we know that the childhood onset usually has a worse prognosis than the late onset diseases, in which in the late onset patients could be as old as 40 to 50 years of age, right? And these cases usually have fovea sparing, hence they have a better prognosis, right? So just knowing a little bit about what this is the most important, most common disorder. So you will need to know slightly more about this disorder as opposed to other dystrophies. So the ABCA4 gene it codes for the protein which is located in the photoreceptor outer segments. And this gene has a role in the visual cycle in which it helps in the removal of the toxic metabolites, in which lipofuscin is the main metabolite which needs to be removed. What happens in this disease is there is a mutation in the ABCA4 gene on the chromosome 1. This hence causes a toxic accumulation of lipofuscin, in particular A2E. The component is A2E, and this collects at the RPE level. This is known as the flex. And these flex or the lipofuscin deposits are toxic to the photoreceptors in the RPE. Now, it would be slightly interesting to know, right? How would these flex be different from drusens? Although it can be a difficult thing to say clinically, but just a pointer would be that these flecks are slightly more elongated as opposed to drusens. Drusens are either small or large, and they're slightly more fluffy as opposed to flecks, which are more compact and are either pisiform, which is have a fishtail appearance. Right? Of great importance is to know that 30% of these patients do not have flecks. So it doesn't mean that Stargardt's, although we've spoken about the fact that macular atrophy, flecks, and the peripapillary sparing is an important feature, but 30% of these cases will not have any flex. How do these patients progress or see, right? Initially, these patients will have normal fundus, very difficult to differentiate it from other pathologies, right? Then you have a loss of foveal reflex, and there are some certain central RPE defects that happen. Then there are these perifoveal flex, which later land up having a familial fundus. This is a characteristic name that is given to a lightish brownish hue that is there all over the fundus, and a beaten bronze appearance, which happens with the macular atrophy. There is a sheen which forms underneath. And you have a bullseye pattern. After this, these flecks invariably land up going and reaching beyond the posterior pole and around the equator as well. Of note here is the fact that discs and vessels are normal in these patients. So we do not get confused. As Meghna was talking, that the discs and vessels, she was suspecting some pathology, but these patients generally will not have, right? So there are multiple classifications for Stargardt's, Fishman classification being the most common, in which they are both clinical as well as electrophysiological changes, in which they are stage 1, 2, 3, 4. ERG classification, fundus autofluorescence classification, and genotypic classifications are also known. ERG classification is important prognostically as there are 3 groups. In group 1, you have the pattern ERG being abnormal, although the full field ERG is normal. Group 2 has a cone abnormality, and group 3 has a cone and rod abnormality. Why is this important? Because of prognostication, right? Group 1 have the best prognosis as opposed to group 3, which have the worst prognosis. Now, it is important to know that ERGs are generally, that is full field ERGs, have a mass response. So, and this pathology, Stargardt's, is a macular pathology, right? And hence this pattern ERG is used. So full field ERGs in these cases are generally normal because it uses the gross response of the retina and not macular responses. But that's the reason we use pattern ERGs in this classification. Fundus autofluorescence is of great use in all these inherited retinal disorders. It is a non-invasive technique. It helps us in knowing the progression of the disease, and it can be repeated at will, right? And these classifications have been used specifically in Stargardt's because it's known to prognosticate and help in knowing the disease follow-up. 3 types of autofluorescence patterns are known. First one, as we can see here, is a type 1 in which there is localized hypoautofluorescence with a homogeneous background. You can see that here, right? And here you have a localized hypoautofluorescence with a heterogeneous background. Here in the third type, we have a multiple areas of low autofluorescence along with a heterogeneous background. And it is evident if you see here at the follow-up, this is 7-year follow-up, this is 11-year follow-up, that the autofluorescence patterns are changing. That is, they are worsening in the right column. And here, this helps in knowing the progression of the disease. Hence, the importance of fundus autofluorescence in Stargardt's disease. Lately, in 2018, there's something called as ultra-wide field fundus autofluorescence, right? And these classifications have helped us know more about the pathology. So nowadays, these classifications are also used. We spoke about autofluorescence. It needs more time here as to because they have a great prognostic value. There are 2 types of autofluorescence. There's something called a short wave autofluorescence and near infrared autofluorescence. The near infrared helps in knowing the progression of the disease even before the short wave, which is a blue autofluorescence, right? Here we can see in the short wave autofluorescence that this is a hypoautofluorescence. These are flex on clinical examination, and these are hypo in this, and they are in NIR, they become hypo, right? Hyper in short wave and hypo in near infrared. And here, if you can see that the near infrared helps in knowing the foveal anatomy better. And here we can see a hypoautofluorescence of the fovea as opposed to the short wave autofluorescence here. So again, to add to the armamentarium, we have the FFA and the OCT. The FFA classically shows a dark or the silent choroid, which is seen in 60% of the cases. Why this happens? The lipofuscin deposits all over the fundus, and it blocks the underlying choroidal vessels. OCT is an important tool in the armamentarium of retina specialists. But the earliest sign in the Stargardt's disease is the thickening of the external limiting membrane. It can be seen as early as 5 years of age. And when we see here, there is a thinning of the fovea. Eventually, these diseases land up having a thinning at the fovea. And if you can see clearly here, there is a loss of the ellipsoid, which is the outer retina, correct? And this, we know that these patients will have a much worse prognosis in terms of vision as opposed to those who are having a rather intact ellipsoid layer and a thicker retina. Can a third year, please, Meghna, can you just tell me what this investigation is? You want to take a guess at what this investigation is? Anybody?
I think Meghna can take it better. She has a thesis on the same topic.
Fundus fluorescent,
Oh, great.
fundus fluorescent angiography,
No, it's
OCT angiography, OCT angiography.
Correct. So this is an OCT angiography, correct? This is a fundus picture, this is an infrared reflectance, and these are OCT angiography pictures. These are slabs, this is at the superficial level. You can see the vessels more clearly. Here, these are the deeper plexus. Here we can see there is an entire blush of vessels here, and this is the choriocapillary layer, right? What we see in this Stargardt's disease is there is a reduction in the vessel density in the superficial capillary plexus, the deep capillary plexus, as well as the choriocapillaries layer. And this is a new finding in which this helps us to, again, know the disease better. All right. What is this, Meghna? What investigation is this? Anybody, any other person wants to take this up? What investigation is this?
like to try Retinoschisis?
No, sir.
Okay, so this is a multifocal ERG. These are called trace arrays, and these are plot arrays, right? These diagrams, and these are trace arrays in which you can see here. Generally, the foveal responses in the center are diminished or reduced on multifocal ERG, right? And full field ERG, like I said, is a mass response. Hence, we will usually have normal full field ERGs as opposed to the multifocal ERGs, which are specific for macular diseases. If you can see clear here, if you observe, these wavy patterns are slightly more blunted here as opposed to the perifoveal responses, right? So this is characteristically seen in these macular pathologies, and multifocal ERG helps us in diagnosing these. Right. So management of this, there's no treatment for this pathology. But what we'll end up doing for these patients is giving them supportive care in terms of low vision aids. You tell them to avoid vitamin A as opposed to other pathologies in which we do administer vitamin A. Avoid UV exposure. Why? Because the primary pathology is due to the visual cycle problem, right? The lipofuscin deposits because of the problem in the visual pathway. Treatment avenues are multifold. Although this is currently there's no treatment available, but there are multiple clinical trials going on in the form of stem cell transplantation. There are various compounds in the form of inhibitors of the complement factor 5, which in Zymura. Then you have emuxistat and others. Gene augmentation, as in gene therapy, is a pivotal clinical trial in this particular disease, as it's the most common disease, most commonly inherited macular dystrophy. And of note here for PGs and in general for your information also is that this ABCA4 gene is a slightly bigger gene. So usually these gene augmentations, gene therapies are done via the adenoviral associated vectors, right? But it's small as opposed to the ABCA4. Hence, these lentiviral delivery vectors are used for this particular disease, right? Just for the exam. To complete for the exam point of view, there's something called as autosomal dominant Stargardt-like macular dystrophy, in which you have these two particular gene mutations. This is a slowly progressive disease, but has advanced vision loss. The striking feature of this OCT feature is the ONL atrophy, and these PROM1 gene mutations usually have, along with it, diffuse and patchy RP atrophy as well. Right. So these differentials, now if I have something like these, can the final years take this up and quickly run through these differentials? So we know, like, if these patients come, how do we know that this is a Stargardt's patient as opposed to the other? So these are all bullseye maculopathy type of pictures, right? So how do we know these are different from Stargardt's? I have given you these clinical pointers as well. Hello?
Yeah.
Hello?
Can you from the left-hand side? Harshit, there is some problem with the.
Hello?
Uh,
Hello?
yeah, I can hear you. Durga, can you hear us?
Yes, sir.
Yeah. So try and answer from the left-hand side picture. The photophobia, nystagmus, and normal color vision.
Say history of any drug intake like hydroxychloroquine.
No. See, okay. There is in the right side.
Bullseye macula. Yeah.
So these are all differential diagnoses
Okay.
for bullseye maculopathy, right?
Yes.
So,
So what I think you're talking.
okay, so the first patient has photophobia. Okay, so this patient, these are differentials that we see here on the left would be for cone dystrophies, right? Cone and cone rod dystrophies generally have photophobia as the most important problem. They are come along with nystagmus, and obviously, as cones are a pathology, color vision abnormalities are seen. Here, this patient, as we see here, has a history of drug intake for rheumatoid arthritis. So what could this drug be?
Hydroxychloroquine, sir.
Correct. So can you tell me what this? Do you know what this thing is on the OCT? What does this look like? It's a classical OCT feature which is called as the flying saucer sign, right? So this is something you can use in MCQs and even like in Vivas this can be there. So the third picture here is a 70-year-old male who has no other illness. There are these drusens here. There's a hemorrhage here. What could this be? So this is basically an ARMD, right? This is a frank CNV also. There is a choroidal neovascular membrane here, but this is a case of age-related macular degeneration. This is a patient who has a well-circumscribed crater in the center of the macula. What could this be? And has low vision since many years.
Sir, looks like a macular oil.
Correct. It's a macular hole. So yes, what I've kept is these are simple differentials for bullseye maculopathy. Here is a cone rod dystrophy. Here is a chloroquine toxicity. Here is age-related macular degeneration and chronic macular holes. So we need to remember when we see a bullseye maculopathy, these are the possible differentials, right? We heard about the flecks in Stargardt's disease. There are other diseases which have fleck as well. So these are called fleck retinopathy or fleck retina syndromes. Any idea what these two diseases are? Anybody wants to take up? Just tell me what this is. So fundus albipunctatus is a type of CSNB, correct? And RP albicans is a form of variant of retinitis pigmentosa. How do we know this? What are the differences? Right? Both of them will have nyctalopia. Both of them will have yellow to white dots, which are radial in fundus albipunctatus and not involving the fovea, right? And they'll have depressed rod response, which recovers after dark adaptation, as opposed to RB albicans, in which there is arteriolar attenuation, which is in conjunction with the retinitis pigmentosa and has depressed ERG, which does not recover with dark adaptation, right? Then you have something called as familial benign fleck retina, in which the vision is normal and the ERG is normal. These are absolutely similar clinical pictures. It's very difficult to differentiate them. But what we'll end up seeing is we need to know these other biomarkers or clinical pointers. And there is something called as fleck retina of Kandori, in which there are larger patch-like flecks. Right? This is for the exam point of view, and sometimes clinically these can be difficult to distinguish. So what do we learn about Stargardt's? There is a triad of macular atrophy, there is flex, and there is peripapillary sparing, right? In these other cases, their peripapillary area could be involved, but in Stargardt's, there is a characteristic peripapillary sparing. We need to remember that 30% of these cases do not have flex. Fundus autofluorescence, OCTA, and OCTA are absolute must, which helps us in diagnosing these patients. And this is a disorder which has maximum clinical trials in terms of all other, in terms of stem cell transplant and other modes of treatment, right? So we need to know, because if patients are coming to us, certain patients are, when you get into clinical practice, patients would want to know, and this information is pivotal. All right. Anybody? Okay. This let's. If you want to take this up, just describe the lesion.
So the first picture is an autofluorescence picture of the both eye fundus, showing hyperfluorescence in the macular region.
Okay.
It is not. Um, so it is well described. The borders are
So there is a
well
circular
described.
circular hypoautofluorescent area,
Area.
mildly hyperautofluorescent, along with these spoke-like patterns. If you can see, right? Can you see these
Yeah.
spoke-like patterns here? Isn't it
Yes,
like
sir.
kind of petaloid
Yes, sir.
spoke-like pattern? And I don't know if it is not that visible in this, but even the clinical picture has this, right? Here, you want to describe this, you will have in examinations to describe these OCT images as well, right? So do you want to take this up and describe? Just what do you see here? Okay, what do you see?
Um, so there are bands of adhesion kind fibrous.
Okay, these are hypo. Whenever you're talking in terms of exams, autofluorescence will be hyper. FFA will be hyperfluorescent. ICG will be hypersenescence, and in OCT it will be hypo and hyporeflective, right? So these are
Okay.
hyporeflective spaces, correct? These are hyporeflective spaces in the retina, right? So these are most
Okay.
likely cystic spaces or skytic spaces.
Okay.
Fine.
Okay. Okay.
Okay. And the level, obviously, you will get to know this is not that clear a picture, but the level also you know where these cystic spaces are. Okay. So this characteristic picture is of a X-linked retinoschisis. Why this is the case? Because we know that it is bilateral, right? Bilateral cases, similar picture, X-linked retinoschisis. So what is schisis? It is a split in the neurosensory retina. We know there are two types of retinoschisis. It's congenital, which is X-linked, and which primarily has a splitting in the nerve fiber layer, and degenerative, which can be typical and reticular, typical having in the OPL and reticular having in the nerve fiber layer. Right? How does this XLRS, what is the general presentation and what is the progression, right? So XLRS is seen due to the mutation of RS1 gene, which is on the X chromosome, and the basic pathology lies in the protein of retinoschisin, which is a cell-to-cell adhesion protein, right? The pathophysiology is unknown, although there are multiple theories that are put. Vitreous traction theory, because there is a vitreoretinal interface which causes traction, as well as these retinoschisin interacting with the sodium-potassium ATPase pump, which causes a extracellular fluid involvement. Right? How do these patients present? Usually, these patients have a diminution of vision in the first to second decade of life. After this, they are stable until the fifth to sixth decade, when the chronic changes of atrophy start setting in. How do these patients in the first to second decade land up with us? They either will have reading difficulty, strabismus could be a problem, anisometropia, and these patients will usually have an unexplained vision loss. Prognosis in these patients is generally good in childhood, right? How do these X-linked retinoschisis progress? There are two ways, right? It's either gradual, which is a more common way of progression, or sudden. In gradual progression, there is a macular atrophy and the coalescence of cysts. These cysts, which, like we have seen here, if there are these cysts, right? These cysts land up coalescing eventually, and they cause a diminution of vision. All right, and there is macular atrophy. These cysts land up collapsing and causing an atrophic area in the macular region. The sudden onset loss of vision can happen due to retinal detachment, which can happen in 3 to 6% of the cases, and vitreous hemorrhage, which is the most common complication, which happens in 40% of the cases. And rare patients even have neovascular glaucoma. As we know, X-linked retinoschisis has two important schisis involvement. Either it's in the fovea or the periphery. Foveal involvement is seen in almost 100% of the patients. Like I said, it's a spoke wheel or a stellate pattern, which is characteristically seen. These small cysts are centered around the fovea in a radial pattern, which is again due to a stellate pattern. And these radial patterns land up regressing with age. Okay, and that causes a blunting of FR. These cystic spaces that we see, we do not see them as the age progresses. So we may just think of it as any other atrophic change, but probably in the earlier stages, they could be having a stellate pattern. Peripheral schisis is noted in almost 50% of the cases, and the most common quadrant is the ITQ. As we can see here, this is an optos image, and when we see there is an ITQ, there is a retinoschisis, and which is confirmed by the OCT here, right? There was many classifications based on the schitic involvement. There is foveal cystic schisis, macular lamellar schisis, and peripheral schisis. The middle macular lamellar schisis is a term used when clinically we see that the fovea is normal, but on OCT we end up finding these changes, these cystic changes. There are these 4 types of changes. XLRS, type 1, which is foveal, type 2, foveo-lamellar, complex, which is the most common, having 70%, and the type 4 with foveo-peripheral retinoschisis. These retinoschisis can also be exudative, in which they can have hard exudates. The pathology could be either due to vascular involvement or something else, but these can be either exudative or non-exudative. OCT, again, as we know, is a very important tool. Intraretinal cyst, as Meghna was talking about, is seen most commonly in INL. See, we've been traditionally taught, and we still know, and we still, from the exam point of view, we are going to say that the NFL is the layer that is involved in XLRS. But when we see on OCT, because these are more diagnostic, we have come to know that INL is the most common layer in which it has been involved, after which it is the OPL and then the GCL. Macular atrophy, as we see, I've told you, occurs later in the course, and the visual outcome depends on the outer retina, which is the ELM and EZ and IZ defects. OCTA, again, an important upcoming tool which is used in most of the higher centers, shows a petaloid non-reflective area in mostly in the deep vascular plexuses, and the microvascular alterations are similar to the PFTs, which show a perifoveal involvement. The fundus autofluorescence, like we spoke about in the first picture, has a characteristic spoke wheel pattern. This usually happens due to the luteal pigment displacement, right? And this is seen in almost 50% of the cases. Of high importance in terms of exam and clinically also is the finding that in FFA, these chytic spaces, we would expect these spaces to have a leak. A CME due to diabetic retinopathy will have a leakage, but these do not have a leak. So this helps us in knowing that this could be a different pathology and not just a regular CME. One of the most diagnostic features, or rather assisting features in diagnosing X-linked retinoschisis is the fact that this is a negative ERG that is seen, right? So here, if you can see, there is the B, this is a regular A wave and this is a B wave, right? But here we see that the A wave is kind of normal, but the B wave has flattened out. So the B by A ratio, which is generally spoken of, has reduced. And this is called as characteristically electronegative ERG. And this is seen in inner retinal pathologies like X-linked retinoschisis. So how does this sequelae happen, right? X-linked retinoschisis is important, again, from the term of exam and also clinically. So why is it, what is the sequelae of these patients? They have inner retina has holes or fragments, which later is termed as vitreous veils. There is a nasal drag of the retina, new vessel formation can be seen, inner and outer retinal breaks. We need these two breaks for the retinal detachment formation. There cannot be just an outer retinal break or just an inner retinal break. These both breaks need to be there to form a retinal detachment. These peripheral changes, retinal changes in the form of metallic sheen, silvery ILM reflex, RPE changes, and other tapetal reflex, also known as mesophenomenon, can be seen. Meghna, can you tell me mesophenomenon is characteristic of which disease? It's a Viva question.
She could not hear.
Oguchi disease.
Correct, very correct. So Oguchi disease, but we now know that even in XLRS it is there, and there are other phenomenons as well. In Stargardt, in combined cone rod dystrophies, mesophenomenon can be seen. Management is basically ambulatory in the sense that strabismus, amblyopia, and refractive errors need to be corrected. This is the main problem that these patients come up with. Although there are no specific treatments, carbonic anhydrase inhibitors have been attempted in terms of topical dorzolamide and oral acetazolamide for the schisis. This has an equivocal result, but the practitioners generally prescribe this. Two major clinical trials in the form of gene therapy for this particular disease is ongoing, and using the adenoviral vector with the intravitreal route. And again, the management of complications like vitreous hemorrhage and retinal detachment. XLRS has a much more difficult prognosis in terms of retinal surgery. This is not any other retinal surgery because there are these other challenges in terms of the pediatric age group. So the decision for surgery in foveal and peripheral retinoschisis is complex, multifactorial, and physician dependent. Why this can happen? The certain reasons are the posterior hyaloid separation is critical in XLRS, right? And we know that the posterior hyaloid is fairly adherent for these pediatric age group. And if it's incomplete, it lands up causing the risk of PVR increases and other contraction-related RDs. And outer retinal breaks, which are difficult to find, right? We know that it is the RD is because of them, but it's still difficult to find them intraoperatively. So these factors need to be weighed in before we go ahead and operate. There are other certain differentials acquired as opposed to XLRS. Acquired can be late in onset. That there is no gender predilection. We know that XLRS is obviously seen only in males, and the females are only carriers with rarely any symptoms. Fovea is a 100% involvement in XLRS as opposed to acquired, which can have outside the fovea. Like I said, there are two forms of XLRS, the exudative and the non-exudative form. The exudative form can be confused with Coats disease, FEVR, uveitic RDs, and retinoblastoma, each of them having other pointers for us to know and differentiate. Right? The non-exudative form can be in terms of pediatric RDs and myopia. Meghna, can we differentiate retinoschisis from retinal detachment? Do we have some? Can you tell me a few pointers? Yeah, can we tell me some few pointers?
Cystic spaces will usually be not seen in case of a retinal detachment.
Okay. No, so see, okay, foveal spaces we're not talking about. If there is a peripheral, see, if there is a picture like this, right? You need to, I hope you get something out of it. If there's a picture like this, how do I know this is not an RD? Like, why can't this be an RD? Why am I saying this is retinoschisis? Okay, this is a picture, but when you're clinically seeing it, how do you say that that's not an RD? Okay, fine. So there are these certain important factors, right? So retinoschisis is generally located in the infratemporal quadrant. These schises are usually bilateral. The appearance, there is a corrugation in retinal detachment, which is usually not seen in cases of retinoschisis, right? These wrinklings will not be seen. Scleral depression is an important factor in which there is no flattening. When we depress the retinoschisis, there is no flattening as opposed to retinal detachment, which can partially flatten. Visual fields are important in that retinoschisis is an absolute scotoma, whereas retinal detachment is relative scotoma. Obviously, the layer of involvement on the OCT is an important factor. And when we laser, these are said that laser does not take up in retinoschisis, and laser does take up in retinal, does not tend to take up in attached areas of retinal detachment. All right. This is an important distinction, not only clinically. I remember in my final year exam, this was a 10-mark question, right? So this is not just clinically, also for your exam, these differentiations are important. Then foveal schisis can be confused with cystoid macular edema. ONH pit has associated macular schisis. Then when we spoke about the non-leaking macular edema, right? These FFAs do not leak. In a similar fashion, there are these other differential diagnoses for non-macular edema. That is the Goldman-Favre syndrome, retinitis pigmentosa, and nicotinic acid pathologies. These have macular edema, but they will not leak on FFA. Goldman-Favre will have other problems like nyctalopia, cataracts, and an optically empty vitreous. Negative ERG is again an important, when we see a negative ERG, we can still confuse it with a CSNB because these are the differential, CRAO, or a melanoma-associated cancer as well, retinopathy. Okay, so these are, any idea what this picture could be? Meghna, you want to take this?
I don't know.
Okay, so this is an OCT slab. These are OCT slabs of OCTA, right? These are B scans of the OCTA. These are vascular complexes which are seen. So this is an OCTA picture. The left side, so this is something called as XLRS, and there is a terminology. This is something you guys should know. Is called as stellate non-hereditary idiopathic foveomacular retinoschisis. This could be used in MCQs as a spotter as well. The differences are mainly not that clinical, but in OCT, these are OCT features. The split in XLRS is in INL as opposed to split in the OPL in SNIFR. there is RS1 mutation present in XLRS as opposed to there is no mutation seen here. These signals, as we see here, right, these show vascular flow signals due to the bridging vessels between the ICP and the DCP in the Henle's layer. These bridging that we see here in the OCTA are due to the vascular flow signals, but here in the sniffer, there isn't any. So these are basically Muller cells which are there. Earlier we used to think that the retinoschisis are due to these Muller cells, but later on, because of the OCTA and the advent, we get to know that these are actually flow signals. These are vascular bridges of ICP and DCP. That is a intermediate and deep capillary plexuses. All right. Just the salient features. What do we take away from XLRS? We know that 100% have foveal schisis, but 50% have peripheral schisis. So when we see a picture like that, we need to examine the periphery and see that there is a peripheral schisis as well. The hyporeflective spaces, the cysts that we spoke about, are most commonly seen in a nuclear layer. FFA, as we have spoken, has no leak. A negative ERG is again an additional diagnostic factor, and the most common complication is vitreous hemorrhage. Diving in for surgery in these patients has to be a fairly is a difficult thing. So we need to take into consideration a lot of factors because you can cause more harm instead of causing good to the patient, right? So this was XLRS. A few more dystrophy. Okay, anybody wants to take this up? There's a 31-year-old male complains of mild diminution of vision in both eyes, no systemic illness or allergies, and father had a similar clinical picture. Meghna or anybody, any other final year?
Vinci, Durga.
Somebody else take it up, just describe, right? These are all exam cases. These are spotters, if not more. Okay. Nobody?
In the participants, just can raise their hand. I can unmute them. If anyone in the audience want to answer, they can unmute themselves. The option is open.
Okay, so I kept these only for the exam going PG so that they can describe the lesion for their exams. Never mind. So these are basically familial dominant drusen. We'll get to know a little more about them. So it's also called as Doyne honeycomb retinal dystrophy or Malaysia leventinese. It is an autosomal dominant disorder with a missense mutation in the EFEMP1 gene causing chromosome 2. This dystrophy, as opposed to others, we see as a later onset, right? Earlier we were seeing that these diseases were in first 2 decades, but this we see as an onset in 30 to 50 years of age. How do these patients present? They have an early, they have a central vision loss. They can have photophobia, and later on they can even have color vision abnormalities. Here we see in these clinical pictures, here we see there are these multiple yellow, white dots. These are drusens, basically, subretinal drusens. They can be small radial drusens, which are slightly more. We have a radial pattern, and on the posterior pole, you have a larger drusens. This is an autofluorescent picture in which there is an atrophic area hypoautofluorescence here and a hyper autofluorescence of drusens, which is typically seen because of the small radial drusens, and as opposed to the AMD drusens, which have a hypoautofluorescence. Is this getting too much or?
No, totally fine. But
okay.
Clock.
If anybody has any doubts, I've kept it very basic. Please feel free to ask anytime. All right. Again, a characteristic feature here is the peripapillary drusen, right? So here you see drusens here, and in other pictures you have peripapillary involvement and this hyper autofluorescence, which sometimes these drusens may not be seen. A clinical picture, we may think that this could be a Stargardt's or something, or some other fleck retinopathy. But if we find on AF, on autofluorescence, if we find a peripapillary involvement of drusens, we can think in terms of familial dominant drusen, right? OCT, again, as we know, is an important tool. These diseases, this familial dominant drusens has a preserved neurosensory retina. Small drusens, although hypoautofluorescence, have a peculiar pattern which has a sawtooth appearance, right? Sawtooth-like appearance. And the larger drusens, which are seen more in the posterior pole, can have a diffuse RPE elevation or dome-shaped elevation. Disruption of RPE, the ellipsoid zone over the RPE, are the result for the loss of vision, which can be seen more often in case of larger drusens. So the FAICG, again, the large drusens are initially hypofluorescent and later become hyperfluorescent, which is similar to the AMD drusen. And the smaller drusens, which are radial in pattern, are initially hyperfluorescent and later become hypofluorescent, as we have seen here. If these, okay, right? And ERG, as is, this pathology is a macular pathology, is generally a normal ERG is what we observe, right? Management, there is not much that is offered in this particular disease, but lately there are some studies which have shown laser photocoagulation has halted drusen enlargement, although it has not prevented either a secondary complication, an atrophy or a CNV, and neither has it improved vision, but promise has been seen in terms of halting the drusen enlargement. Intravitreal anti-VEGF has been used for secondary CNV, although rare, but these have been used. Potential approach in terms of gene therapy has also been sought after. So what are the characteristic features? Peripapillary involvement, which was not seen in, like, if you remember Stargardt, there was a peripapillary sparing. This particular disease has a peripapillary involvement. Smaller radial drusens are seen, and larger drusens are seen in the posterior pole. The inner retina is relatively spared, and there is a disruption of ellipsoid zone, which causes the loss of vision in these particular patients. And laser photocoagulation has seen some benefit. Coming to the last few dystrophies, anybody wants to take this up? A simple picture here.
Vinci?
Just describe. I don't want anything more. Just describe the picture. That's it.
Autofluorescence showing well-defined macular lesion.
You want to go with the fundus image first?
Sir, yes. Disc appears normal. Blood vessels are also normal. There is a well-defined lesion in the macular area.
Well-defined.
Atrophy.
Okay, so it's a well-defined yellowish circular lesion centered at the fovea, right? This is a autofluorescence image in which we see it's an IR image actually, in which it shows a hypo-reflective area here. This is an OCT which has a subretinal and a this RP, if you see faintly, is here. This is a subretinal deposition in the subretinal deposition at the fovea. Right. So this is a typical picture that you see in Best disease, right? So we know something about Best disease. It's the second most common macular dystrophy seen in 1 in 10,000 population. It is an autosomal dominant inherited disease with BEST1 gene mutation caused on the chromosome 11 for the bestrophin protein. Right. There are these other pathologies, the adult onset vitelliform macular dystrophy, the adult autosomal dominant vitreochoroidopathy, autosomal recessive BEST, and RP, which are also called as bestrophinopathies. This is because of BEST1 gene mutation. Right. These diseases have an onset of around 3 to 15 years. These patients usually have a hyperopia. It's kind of obvious why, because you can see there is a slight bulge here, right? This bulge, wherever there is in the center, if we can expect a slight hyperopia in these kind of pathologies. This autosomal recessive BESTs, as I've spoken about here, are usually associated with angle closure glaucoma. It's a progressive diminution of vision is seen in the 4th decade due to atrophic changes, right? So at the onset is around 3 to 15 years, but the diminution of vision starts after around the 4th decade due to the atrophic changes. It has various clinical stages. This is important in terms of your exam because there are many questions that can come for this, right? So the characteristic features in the initial subclinical form, right? There are multiple forms. There are different books which have classified it differently, but in general, there is a certain pattern which it follows. Subclinically, it has a normal fundus, but the EOG is abnormal, right? Pre-vitelliform may have some subtle RPE changes. Here we see that there is a vitelliform lesion. If you can see here, this is a horizontal scan. If you do a vertical scan through this, it's a vitelliform lesion. It has characteristically, it is called an egg yolk appearance, which has a diameter of 0.5 to 5 mm. And it is on FFA. If you examine this, it will be hypofluorescent, right? If FFA is here, it is hypofluorescent due to the blockage of this vitelliform lesion. Next is the pseudo-hypopyon stage. If you can see here, there is a partial resorption of this deposit. This vitelliform deposit enlarges, and there is a slight resorption, right? And there is a superior fluid level. Again, this is a horizontal scan. If we did a vertical scan, you can see this thing here, which is a deposit. If we do the scan here, there would be a fluid level here and a deposit inferiorly. In the same way, fundus fluorescein angiogram would have shown a superiorly, because of the fluid, would have shown hyperfluorescence, and inferiorly would have shown a blockage hypofluorescence. Vitelli eruptive form is the next form. These pseudohypopyon and vitelli eruptive are interchangeably given in different textbooks, but in this stage we see a scrambled egg appearance here, and the vision significantly drops. The reason this stage is important is until these stages are there for a good 20-30 years, this is fine, but when this stage appears, whenever it does, the vision significantly drops. And in the later stages, it's either atrophic or a CNV forms, and all deposits are resolved, and there's a window defect causing a hyperfluorescence. Right? So these are various clinical stages. The most important diagnostic feature for this particular dystrophy is the EOG, because the ERG will be normal, but EOG is the one which is used even for screening the asymptomatic carriers. As we have seen, that this can be subnormal or abnormal even when there is a fundus which is normal, right? So this can help us distinguish from other pathologies, and it's a diagnostic for this particular disease. The Ardens ratio is something we need to know. It is less than 1.5, and it is somewhat...
इसका क्यों खत्म नहीं होता 45 minutes में?
So the prognosis is relatively good until 4th to 5th decade, and there are low visual aids is what the treatment is: smoking cessation and anti-VEGF or PDT for CNV. Right? This we can skip. The salient features for best is early onset and late progression, well-defined yellow lesion and absence of flex, EOG, which is diagnostic, which is less than 1.5, and bestrophinopathies. Anybody wants to take this up? Any PG here wants to take it up? Okay, so we'll run through this. This is slightly uncommon, but still important in terms of macular dystrophy. It's called a SOSB, pseudo-inflammatory dystrophy. It's also called as hereditary hemorrhagic macular dystrophy. So the genetics, it's autosomal dominant with a TIMP3 mutation. The onset is usually, this is again a late onset disease, 4th to 6th decade. Presenting features, this particular disease has nyctalopia, night blindness, metamorphopsia, and vision loss. These clinical features, they usually have drusen-like deposits, and early in the disease, there is central and peripheral chorioretinal atrophy later in this disease. Progression, there is slow macular atrophy, and rapidly, we see whenever there is a rapid progression, it is due to CNV. Management, vitamin A has been tried, but it's an equivocal response, and CNV is managed by anti-VEGF injections. The differentials in this case is, again, age-related macular degeneration because of the late onset, ADD, that is autosomal dominant drusens, pattern dystrophies, BEST, and CSR. The reason this is important to know is because of AMD, how it can be confused. These have a similar clinical and histopathological similarities, and TIMP3 mutation is seen even in the AMD cases. Right? Salient features here, this is that macular dystrophy, which has nyctalopia. None of the other previous ones had them. It mimics AMD closely, and there is macular and peripheral CRA, which helps in distinction from the AMD cases. Then we speak about the pattern dystrophy. These are a group of disorders, a heterogeneous group of disorders with autosomal dominant with PRPH2 gene mutation. They have yellow, orange, or gray pigments at the macula, and usually have a mild to moderate visual disturbance with a benign course. They have a normal ERG and usually have an adult presentation. Here is again a case of pattern dystrophy. Anybody, any final year here to take this? This is an important case because clinically we'll end up seeing these cases.
Anyone even in the audience want to try?
Okay, fine, never mind. This is something called as, these are adult onset vitelliform dystrophy, pattern dystrophy. The reason they are important is they are distinguished from VMD is the normal best dystrophy in that these have smaller foveal lesions. They appear in the 4th to 6th decade. They are not similar in evolutionary stages as best diseases. There is a central pigment around the subfoveal deposit and has a moderately subnormal EOG as opposed to the best disease. Then the other diseases are butterfly-shaped pigment dystrophy, which has a butterfly shape, seen in 2nd to 3rd decade. There is a Jogren reticular dystrophy, which has a reticular pattern, which is enhanced on FA, fundus pulverulentis, and multifocal pattern ERG simulating Stargardt's disease also are seen in these pattern dystrophies. So there are these 5 subtypes which Gas described, and these pattern dystrophies are seen. These are usually missed because we are not able to diagnose them correctly, but they are still seen in clinical practice. They are often confused with age-related macular degeneration, and 50% of these cases are known to develop geographic atrophy or CNV. The clinical pointers here, again, pattern dystrophy has an adult onset. It has a relatively benign course, but yet 50% of these patients can have geographic atrophy and CNV. And there are different patterns as we have seen here. Like there are other rare macular dystrophies, North Carolina, dominant CME, familial ILM dystrophy, occult macular dystrophy. These are just for namesake, but you can just enlist them in your long answers, and that's about it. Anybody wants to just take these autofluorescent images? There are clinical clues in terms of OCT and the genes. So just a brief wrap up.
So A is Stargardt's disease.
Very good.
B is best vitelline dystrophy. Best
Great.
dystrophy.
Okay.
The third one is retinoschisis.
Great. Okay. So this, okay, I can understand this is difficult to see, but there is a TIMP3. If you remember this mutation, there are these just 6 macular dystrophies you need to remember. So this is particularly seen in SORS-B in pseudoinflammatory disease. PRHP2 is again pattern dystrophy. There is this particular pattern of speckled pattern which is seen on hyperfluorescence, is seen on AF, and EFMP1 would be dominant drusens, right? So this is what it is.
Hereditary dominant.
Great. Right, and this is just a brief wrap up of these. Also, these 4 important dystrophies. We can see the onset for Stargardt is 6 to 20, Best is 3 to 15, XLRS is 1 to 2, first decade, and ADD, as we've seen, is slightly 3rd to the 5th decade. Characteristic feature in Stargardt is vermilion fundus, beaten brown appearance. The OCT features have a loss of outer retina. The dark choroid is characteristic on FFA, and the subnormal photopic responses in ERG. Best, as we know on clinical, there are multiple stages, but pseudohypopion stage, egg yolk appearance, scrambled egg appearance are characteristic appearances. They have vitelliform deposits, and they are on FFA, they are hypofluorescence due to the blockage. And the most important feature here is the subnormal ERG, which is seen even in normal fundus, correct? XLRS typically has a spoke wheel pattern. We've come to know now that the hyperreflective spaces are most common in the inner nuclear layer. FFA has no leakage, and a negative ERG is seen in these patients. Autosomal dominant drusen, also called as honeycomb pattern dystrophy, has a peripapillary drusen. If you remember, Stargardt's had a non-involvement of the peripapillary area, but here ADD has a peripapillary drusen. Characteristic sawtooth or dome-shaped lesions are seen, and they are hypo or hyper on FFA, and there is a reduced 30 Hz flicker, right? That's, I think, as much as I could take about the entire macular dystrophies. If you have any doubts or questions, I'll be more than happy to take. I know I've exceeded my time by 10 minutes, 15 minutes, but if there are any questions, please let me know.
So thank you, Harshit. That was really nice lecture, and it was you tried to cover everything, which is obviously a difficult task.
Yeah.
Especially the images were very good. Like they were superb. It was like seeing an atlas and somebody the atlas is talking to you.
Correct.
I enjoyed the presentation thoroughly.
I hope like the final years use it. I mean, this is a PG class. I try to keep it in terms of clinical and based on PG like the exams as well. So hopefully they got something out of this. If there are any questions, Meghana, Vinci, if you guys want to discuss anything. Because it's important that you guys describe. See, even we were afraid, to be very honest, to start describing, but as exams approach, you realize that this is the most important aspect. The more you talk about these things, the more you get refined, right? So,
So there is a question, Harshit.
Yeah.
Why the vitamin A is avoided in the Stargardt's disease?
Yeah, because see, vitamin A generally has the basic pathology in Stargardt is due to the cycle, the entire visual cycle, and there are these bisretinoids which are there, which land up getting deposited because of the lipofuscin. So it aggravates it more than solving the problem, and hence the vitamin A. this has been debated. It's not been, there have been theories that have refuted, but in general and clinical practice, we land up, as a general advice, say that because the toxicity of vitamin A is fairly well known, and these patients, because of their visual cycle problem itself, due to the mutation of the gene ABCA4, this vitamin A can accentuate the problem.
Okay. I hope that answers your query, Ketan. Anyone else? Any questions? I don't think there are multiple questions.
I understand. I mean, it's an exhaustive this thing, so I can imagine that it's.
I just want one question from my side. Like,
Yeah.
you see, this genetic workup is many times important, and you showed in the slide that when do you suspect? So,
Mhm.
if you suspect any such dystrophy, and you want to send for the genetic workup. So, do you do it regularly, or when you have a diagnostic dilemma?
See, what happens, Dr. Sumit, is that it's we live in a country in which we cannot. The problem most important is the cost factor more than anything, right? And we do know that these diseases don't generally have a treatment as of now. So that's the reason most of us land up withholding this information or telling them. But in major centers like Shankar Nethralaya, LVPI, AIMS, what we land up seeing is there are patients who come. Obviously, these are very, very rare that these patients do come, but there is the opportunity that some patients do want to know what their problem is, right? So getting a genetic diagnosis does help. And certainly, like now we know that retinitis pigmentosa, Stargardts and all, these diseases have ended up having these genetic workups and genetic treatments as well, right? If you know that Luxturna is a drug that is used, so these kind of things have come up. So that's the reason it's important. Maybe it's not important at this moment, but what we tell patients is there is trials going on, and maybe 5 to 10 years later, when there are these treatments that are in practice, we can probably offer them to you. But we need to know the problem now so that we can treat you later. That's how we used to counsel the patients when we were in SN. That's how we used to do it.
Okay. Great. Thank you. Thank you, Doctor, for your time, and thank you, Deepak, sir, for being there all of the time. And thank you all, Meghna, Vinci, and Durga, for your active participation. And we'll be meeting on the Thursday again with the next lecture in the series. Thank you, Harshit, once again. Good night.
Thank you. Good night.
Thank you, sir.
Thank you. All the best, Meghna.
Thank you, sir.